Assalamu alaikum. My name is Mohammed. I'm a radiation oncology resident, PGY3, at King Fahd Medical City, and I'm going to present a paper that I have published, factors affecting isocenter displacement planning target volume margin for patients with rectal cancer receiving radiation therapy. I would like to thank the scientific committee for giving me this opportunity to present this paper. So rectal cancer, in brief, the overall lifetime risk of developing colorectal cancer is 4% and is considered the third most diagnosed cancer worldwide. Radiotherapy is recommended for patients with a stage 2 and 3 as a neoadjuvant compared to the chemotherapy. The radiation treatment is delivered either as a short course with a dose of 25 degree in 5 fraction or a long course concurrent with a dose of 50.4 degree in 28 fraction, with a concurrent continuous 5-U fusion or oral cabicitrine. A precise and reproducible daily placement of a treatment isocenter is the main goal for radiotherapy. Pelvic irradiation for rectal cancer is associated with large setup errors that are highly affected by BMI and treatment position. So prone and supine position are commonly practiced for rectal cancer radiotherapy. Prone position is preferred by some centers to decrease bowel volume inside the radiotherapy field, while others believe in more comfortable supine position, especially with the IMRT and VMAT that allows sparing of the small bowel. For fixation, the belly board and back lock were commonly used with a prone position. Belly board allows placement of the small bowel away from radiation beam. In addition, it allows more comfortable positioning for the patient, especially when the patient is obese. Patients with a high BMI are difficult candidates for accurate daily positioning, as skin tattoos are mobile, and the weekly electronic portal imaging device are not enough to correct positioning errors. So how to ensure target volume coverage? BTV margin added around the CTV to account for variation in patient position, organ motion, weight loss. Also to overcome the uncertainty of daily treatment. Electronic portal imaging device are used to ensure proper placement of the treatment isocenter. The theoretical assumption of having less BTV margin for IGRT patient compared with no daily IGRT is valid, however not yet practiced for rectal cancer patient. So the aim of study is to evaluate rotational displacement before and after online correction for rectal cancer patients receiving external beam radiotherapy. Different factors such as treatment position, BMI, and fixation tool were studied and correlated to the setup variation. Systematic error, random errors, and the recommended BTV margin were computed. So the inclusion criteria: patient with rectal cancer who received long course radiotherapy. The patient treated strictly following department policy. Short course were excluded. CT-SIM department policy: patients were advised to have an empty rectum and full bladder. The treatment position chosen by the physician according to the patient capability. The use of belly board, back lock, or no fixation was discussed between the oncologist and the radiation therapist and decided before the CT-SIM for each patient. For verification, key portal image using the import imaging system were acquired. Then online matching with digitally reconstructed radiograph created from CT simulation image was followed. Isocenter shift correction was applied per department policy. Displacement of 3 millimeter shift is accepted without correction. The shift of 3 to 7 millimeter mandated applying shift correction before treatment. Reset up is required for more than 7 millimeter translational shift and more than 3 degree for rotational displacement. Another portal image was acquired after correction for documentation. The portal image were acquired on the first 3 consecutive days of treatment and then twice weekly for each patient. Combeam CT was used for treatment verification at least once weekly. The trend of isocenter shift in the first 3 days for each patient was routinely evaluated by our senior radiation therapist to decide on either daily IGRT or no daily IGRT, keeping the same portal image frequency. For estimation of reproducibility, the isocenter shift was computed using the offline review, matching of reconstructed radiograph and electronic portal imaging device before and after the online correction was done. to calculate the setup errors. The translational setup errors include the three directions, sub-inf, right, left, and anterior, posterior, or calculated. Total vector error was computed for each patient. It reflects the overall treatment isocenter shift from the planned isocenter. It is a mathematical function that takes the three-direction displacement into account simultaneously and computed for each patient from the main displacement. The rotational displacement was calculated separately and measured in angular degrees. BTV margin was calculated using Strom formula, which ensures that 99% of the CTV is covered by 95% of the prescribed dose. For assessment, the translational and rotational mean displacement compared for the treated positions, supine versus prone, BMI groups, 30 kilogram or less versus more than 30 kilogram, fixation aid, backlog versus belly board, and matching image before the online correction was used to assess the recommended BTV margin for no daily IGRT, and matching image after the online correction was used to assess BTV margin for daily IGRT. So 189 patients with rectal cancer treated between 2011 and 2021 were included in the final analysis. We excluded patients treated with short course radiotherapy or due to the unavailability of image, both before and after online correction. So the results showed that the patient treated in supine position showed significantly lower main right, left, anterior, posterior, and rotational and total vector error displacement before online correction compared with those treated in wrong position. The same is valid after online correction, except for total vector error, which did not show significant difference between the supine and wrong position, with a p-value of 0.21. For belly board, device showed higher main right, left, and total vector error displacement before online correction compared with backlog, with a p-value of 0.005 and 0.03 respectively. However, these differences were lost after online correction. The patient with a BMI more than 30 kilograms showed significantly higher main right, left, anterior, posterior, and total vector error displacement before online correction compared with patient with a BMI 30 kilogram or less with a p-value of 0.02, 0.05, and 0.05 respectively. However, there was no significant difference after online correction between the same group. So the recommended BTV margin for no daily IGRT was from 1 centimeter to 1.4 centimeter. For BTV margin for IGRT, it was 7 millimeter. So in conclusion, the computed BTV margin for daily IGRT are lower compared with no daily IGRT. Wrong position and BMI more than 30 kilogram require higher BTV margin in the case of no daily IGRT. However, this is not the same with the use of daily IGRT. The use of embolization device, such as belly board, should be studied by each department to find the optimal BTV margin. We recommend using daily IGRT for rectal cancer, applying BTV margin of 7 millimeter. However, in case of no daily IGRT, margin should be from 1 to 1.4 centimeter based on the BMI, treated position, and fixation tool. We encourage further study examining the effect of bladder and rectal filling on the recommended BTV margin. That's it. Thank you very much.